Good morning, everyone. My name is Andrew Beckett. I'm a Lieutenant Colonel in Canadian Forces Health Services, and I'm the Chief of General Surgery for CAF. And it gives me great pleasure today to be the moderator for the CIMVHR Serving Military Session C. And it's always a great pleasure to be involved with CIMVHR for all the great things they do for serving CAF members as well as veterans and their families. So it's a real honor for me to be able to be moderator today. Today in this session, we're going to be having a number of speakers that are serving military and actively involved in military research and really serving the needs of the CAF and exploring new technologies for health and wellness. So it's a great session that we have lined up here for you. And just as a couple of housekeeping notes, if you're having issues with your stream quality, click here to switch to the alternative stream button below the video player. And that should sort most things out. Now, if you're having other technical issues, click the help button at the top of the menu on the page, and you can send a request to the technical team and a response will be emailed to you immediately. So in our first speaker, it gives me really great pleasure to introduce Lieutenant Colonel Rich Hillsden, who's a colleague of mine from One Canadian Field Hospital. And he's going to be talking about development of a platform for virtual scenario-based team training for combat mass casualty situations, which is, of course, of great interest to CAF as a whole. And I'm very proud to say that Rich Hillsden has been a great colleague of mine for years, and also he just got promoted to Lieutenant Colonel. So this is a great chance to see him in action. So I'll take it away, Rich.
Good morning. To begin, I'd like to say thank you to the CIMVHR coordinators for giving me the opportunity to present my research. My name is Major Richard Hillsden, and on behalf of Mr. Joseph Kolchak, Major Shane Smith, and Lieutenant Colonel Retired Vivian McAllister, we're presenting the development of a platform for virtual scenario-based team training for combat mass casualty situations. I have no research grants or conflicts of interest personally. There's no commercial support for this work. This is primary research, self-funded with no outside influence. The goal today is we're going to talk a little bit about the use of various online meeting platforms to create a high fidelity training experience. We're going to talk a little bit about the different capabilities of some platforms and how that applies to mass casualty training. And finally, we're going to talk about the development of a novel turn-based strategy game that can be used to train military personnel and prepare for mass casualty events. As a background, Canadian Armed Forces Health Services members must be ready for mass casualty events. Regardless of their trade, they need to be prepared on deployment to deal with multiple casualties at a time. Pre-deployment packages in Role 1, Role 2, Role 3, MSRT, for example, all train mass casualty scenarios. And oftentimes when you're in theater, a mass casualty event and scenario is provided as a sort of validation to prepare one team during the handover and change of command. All of these things, though, happen in person, and the majority of our mass casualty training exercises and thinking happens live. The reality is, though, COVID-19 has changed how we have to train our personnel, both in person and virtually. We've had to adapt to the limitations of the pandemic. Many of us as educators have actually moved from in-person content to online content and have found that knowledge transfer might be easier than transferring skills. And I would propose that managing a mass casualty scenario, certainly in the combat environment, is an example of a high skill training demand. So what is a mass casualty event? Well, essentially, it's a situation where the number of patients and the severity of injuries outweighs the personnel and equipment available. Mass casualty events are rare. Few have personal experience. And as a result, training, both in person, virtually, and online, requires some form of simulation. Simulation can be thought of in a number of different ways. It's an imitation of a process, potentially. It's the action of pretending or deception. And in other ways, it could be a computer model representing reality. And what we're presenting today is really an example of all three of these to train someone in a mass casualty scenario. Whenever I think about simulation and my simulation research, I think about the technology versus Fidelity Plane. This is a novel thought experiment that I use for any simulation exercise I'm developing. On the left axis, you can see that there's a technology plane where you have higher technology above and lower technology activities below. And on the horizontal axis, you can actually see the fidelity side. How closely does this training and simulation experience represent real life? So let's see this plane in action. So probably the most obvious simulation that comes to mind is a flight simulator. This is obviously high technology, but it represents the reality for pilots very, very well. So it meets this high technology, high fidelity scenario. Now, not all flight simulators have always been so high tech. At the turn of the 20th century, we see an example here of a lower technology and also lower fidelity flight simulator. But this also helped prepare pilots for that moment when they got into the cockpit and flew the aircraft. Now, for me, I like to think of my very first medical simulation, and that was the game Operation. I'm a surgeon, and so obviously I've advanced far beyond what this game allowed. As a young child, this was my first simulation. One might argue that this was low technology and low fidelity, but certainly it did help you practice skills as far as steadying your hand, which is something that's required in my day-to-day job as a surgeon. Another example of medical simulation is the standardized patient. Here, you have a low technology scenario, but extremely high fidelity experience. The standardized patient is able to emulate what interaction with a real person is like for a medical student. And that experience very, very closely reflects what it's like to take care of a patient. So let me pose this mass casualty scenario here. We have a tabletop. We have some Barbie dolls representing some casualties. They could be ejected from the vehicle or possibly a casualty collecting point. The Barbie cars could represent up-armored vehicles that have struck an IED. Where might an exercise where you're sorting these from a triage point of view be on our technology versus fidelity plane? So that's a little concept as we move into trying to transition to online mass casualty education. So we had this problem with COVID-19 and the need for doing training in a distributed fashion, in a virtual fashion. We needed to figure out how we could use existing technologies, work from home technologies, or identify the possible gaps that needed to be filled with new technologies to provide this mass casualty type training. So let's take a look at our methods here. We developed a working group that specifically was formed with multiple stakeholders, physicians, medical students, and education technologists, to take a look at what were the available technologies, determine if they could be adapted to this problem, and evaluate if new technologies could be developed. And finally, we wanted to use these technologies to deliver mass casualty training. After we delivered the training, we wanted to be able to test it. So we looked at pre and post test surveys. And finally, we recorded this experience. So there's opportunity to review the performance and evaluate our mass casualty program in an iterative process. Traditionally, when you have a traditional curriculum and you're trying to adapt it to new technologies, you have your curriculum, you have the technology you choose to use, and you form the technology or the curriculum to that technology. But our approach was different. We had a goal. We wanted to have people who were confident in managing mass casualty scenarios. And so we wanted to evaluate what technologies would be most appropriate. We would have a working group then take those various technologies and develop a comprehensive mass casualty plan and educational program based on those technologies available. What are our results? Well, we looked at a bunch of different technologies as part of the working group. Zoom, Teams, WebEx, for example. Each of them had advantages and disadvantages. Zoom, for example, very simple to use, but had less capabilities than, say, Teams or WebEx. Teams also had the added advantage of having more add-ons such as whiteboards and forms, which allowed for various types of scenarios to be simulated. So for example, the classroom function of Teams allowed excellent breakout room functionality and incorporation, again, of other apps within the breakout rooms to help facilitate simulation of a mass casualty experience. Forms in particular was a useful tool, as we could use forms to create individual scenarios that would require the students to make choices, and they would get immediate feedback. The whiteboard technology as part of Microsoft Teams also allowed us to simulate what it would be like to be a commanding officer or leader managing a mass casualty situation. We could get them to brainstorm specific ideas of how to manage the problem as it unfolds over time. But despite all that, there was a gap. We struggled to find a technology that would allow us to have patients that behaved in a dynamic way, patients that would change as the scenario would unfold, and allow the combination of both the medical decision-making as well as the strategic decision-making to help stretch the knowledge and abilities of our students. So as a result, we decided to develop a novel turn-based online triage game. This would actually simulate the actual decisions that a provider or trauma team leader would have to make when dealing with multiple patients in a hospital or a Role 3 environment. The algorithm allowed for this scenario to be changed both on the fly as well as changed between iterations, so that every time the game is played, there could be a unique experience. And it allowed us to modify the resources available so that we could train students to work in multiple different environments, such as a Role 1 with limited resources, or even up to a Role 3 environment where there are multiple resources. So this is an example of how the game appeared to the students, and just going to give you a bit of a lay of the land. You can see that there's multiple patients here that you can see on the screen. To the left, we have 5 visible, but the scenario that was tested actually had 25 patients. Then along the top, we have the various resources that could be used, and that would help the students make decisions. And then behind my picture here, there's a play button that allows the students to advance the scenario one turn at a time. So zooming in a little bit closer here, you can see this the game resources again. We have an operating room, 3 operating rooms. We have X-ray, ultrasound, CT scan, ward beds, trauma bays, and ICU. This is very much like a Role 3 environment, certainly similar to what I would have experienced when I was deployed in Afghanistan. You can see below, again, the selections that can be made. Under this weight scenario, there's an up and down arrow. That allows students to choose which resources are being used, allowed them to choose what treatments would be applied to patients, and then the vital signs in the middle column, middle to right column, would change depending on whether they were making the right decisions or not. Outcomes were determined based on whether the patient died or survived, and ultimately the game could be played through till there's a resolution of all scenarios. So I have a still image here. Unfortunately, I can't show a video of the students actually interacting with the game, nor can I demonstrate the gameplay myself due to the limitations of this virtual presentation, which sort of outlines the point. Sometimes the technologies need to be adapted and changed, or new technology need to be created to solve a problem, just like we did here in this game. But you can see we have below these students participating, and they're all interacting with the game. You can see some of the selections here. Intubation, ultrasound, for example, have been chosen. The resources have been used up, and that gives you a sense of the pressure and decision-making challenges of trying to lead in a trauma scenario. So to conclude, we've successfully developed a novel online turn-based educational game for the instruction of mass casualty scenarios. We think there's an excellent opportunity here to be used to train Canadian Health Forces service members in all roles, doctors, nurses, med techs, and for all environments where a mass casualty could occur. We think that this type of game could be incorporated in existing educational programs, such as the medical officer training course, or maybe the advanced military medical trauma training program, as some examples, where a distributed learning component can be added, certainly this mass casualty experience could be incorporated into that already existing training. So a question that I will propose to you: where do you think this novel technology lies on our technology fidelity simulation plane? Obviously, this is my subjective opinion here, but certainly it is a higher technology in the sense that there's novel programming behind the scenes and is moderate level of fidelity. Certainly the students who felt the pressure of having to manage a mass casualty scenario. Certainly the students learned the compromises and choices that would have to be made when you're dealing with more patients and you have the resources to manage, and the feedback related to this experience was positive and reflected on that. I do think, though, there's some opportunities for this to grow and be developed in the future. I would say this game would be in the beta stage where we're testing and refining it and seeing how it works in multiple applications. We can improve the graphics of the interface to make it a little more dynamic. We think additional test groups would be appropriate. Again, as learning needs are different depending on the skill set of the person taking this program. And I actually think this would have a role outside of the military. Our intention, of course, was to train Canadian Forces personnel who are much more likely to encounter a mass casualty scenario in their career than, say, a civilian counterpart. However, civilian training in mass casualties is lacking. And there's an opportunity, I think, for us to improve that training through this novel online program. There's no references here. All of the content here is my original research and the original research of this team. Thank you very much.
Great. Thanks for that, Rich. We've got a few moments for questions now and for discussion. So to start you off, I've got a question for you. What type of injuries do you think could be simulated in this? Could it be the injuries be simulated for example, for different situations? For example, for an industrial accident versus a mass shooting in say public space? Could it be customized, do you think, using this type of platform?
Thank you for that question, Andrew. Yeah, I completely agree. That's the goal here, was to develop a game that could actually be customized for any environment. Obviously, the types of injuries that we chose in our test group were things like traumatic amputations, burns, some gunshot wounds, things that you'd expect on the battlefield. But you're absolutely right. Different communities and different environments might have a higher likelihood, like you said, of industrial type incidences. So how the game actually works is there's a back end interface. We only showed the front end for the presentation, where people who are running the game can actually customize the types of cases that are being brought into the scenario. And so if you're running this course or training a group of people, you can say, all right, well, we're going to choose higher percentage of burns, for example. We're going to pick burn cases that we would simulate maybe fewer amputation cases, if that's the example you want to use.
Great. And there's a question from the audience. It's, what platform was the game developed on?
So this is a web-based platform. So you just have to type in a web address into your browser. It works best in the Chrome browser. We also tested in Firefox as well. And there is a link that's available right now. We're not widely distributing it for obvious reasons, but hopefully down the road, we'll be able to make it broader and more available to the public. But all you have to do is type it in your web browser and it'll work in most standard browsers.
Great. And is your intent to make this available freely on to institutions, or you're planning to develop a company and market this to different organizations?
Yeah, our primary goal is to make this as widely available as possible. In fact, one of the areas we're exploring is possibly collaborating with the Committee on Trauma, and they're in the process of developing and electronic disaster management education program, DMAP. And so this actually might be something that could be included into an eDMAP type of program. Again, we're just in the process of just introducing ourselves to those committee members and sort of proposing this as a way to reach out a bit further. At the end of the day, this was essentially a self-funded project. So, for it to go to the next level, you need to find partners. Our intention is not necessarily to commercialize it through a company, but we are going to be looking through partners, and that might truly be a commercial entity. But for now, we're looking at other, again, like the Committee on Trauma, for example, as a possible partner.
Great. Well, thanks very much, Rich. I'm going to move on to introducing our next speaker, who's Ocean Vartanian, who's a very well-known researcher in the area of blast and mild traumatic brain injury, as well as other types of brain injury. So his talk today is going to be the impact of blast exposure on neuropsychological functioning, preliminary data from the CANSOFCOM high-risk population. And Ocean has been really active in this field for many years, and so it's a great honor for me to introduce Ocean. Please take it away, Ocean.
Hello, my name is Ocean Vartanian. It's a pleasure to be giving this presentation at CIMVHR this year. The title of my presentation is The Impact of Blast Exposure on Neuropsychological Functioning, Preliminary Data from CANSOFCOM High-Risk Population. As you can see, this work was done in collaboration with a number of scientists and technicians at DRDC Toronto and Suffield, and clinicians and CAF members at the Canadian Forces Health Services. My name is Ocean Vartanian. This work was funded by Department of National Defense. There are no conflicts of interest to declare, and there are no mitigating potential biases. In terms of learning objectives, my main job for today is to convince you that there's a difference between the effect that blast exposure has on post-concussive symptoms versus various kinds of mental health outcomes. So typically, in a lot of the work in the past, it's been shown that these two things tend to go hand in hand as a function of blast exposure. And I would like to show you that if the data are collected in the context of training, that you can actually distinguish between blast-induced mild traumatic brain injury as measured by post-concussive symptoms and mental health outcomes. These are the references. Everything I'll be talking about today, aside from the very last part of my talk, has recently seen the light of day. So please access them if you can. And if not, get in touch with me and I'll be happy to share them with you. This is a brief overview of my talk before we start, so you have some kind of an idea of the journey that I'm going to take you on. First, I'll tell you a little bit about the relationship between blast and health, just to set the context for what I'll be talking about today and why it's an important topic of study. Secondly, I'll be talking about some of the results of work that's already been done in terms of published reports, because they're very fresh. And I would like to review them before I set the stage for actual ongoing work right now with CANSOFCOM. That's been running for about 3 to 4 years now almost, which has both a cross-sectional component and a longitudinal component to present to you with some really cutting-edge, fresh data that have just been collected. And I'd like to end with covering some conclusions on future directions. So as a lot of you will know, there is a lot of work out there already looking at the impact of blast exposure on health and performance. It's an important topic to study because between 10 to 20% of military members who come back from various theaters of war will have reported sustaining a traumatic brain injury. This is particularly worrisome because about 10 to 15% of that particular group tends to show persistent symptoms in the post-concussive range long after the initial symptoms have resolved. So it's a problem that is prevalent and persistent. Now, blast exposure can, of course, result in a long list of negative health outcomes, including mortality, morbidity, traumatic brain injury, post-traumatic stress disorder, and chronic pain, to name but a few. Now, one thing that's made studying this topic really tricky is that we know that there is a comorbidity between blast-induced traumatic brain injury and post-traumatic stress disorder or depression. In other words, a lot of military members who come to the clinic following exposure to the theaters of war will report these two outcomes concurrently. And this is perhaps not surprising because the events that led to traumatic brain injury that's blast-induced typically will involve circumstances that are also emotionally traumatic. So the person will have a particular set of symptoms that are characteristic of traumatic brain injury, of the blast-induced variety, and post-traumatic stress disorder / depression. Now, this is complicated because when it comes down to choosing what's the best kind of intervention strategy from a therapeutic perspective, the decisions will not be clear-cut because of this overlap. So the question is, well, given this comorbidity that we see from members coming back from theaters of war, is there some kind of another context within which we can study the effects of blast that will allow us to distinguish between these two sets of outcomes? And it seems that we have one in the context of breaching. So breaching is what's undertaken when military members strategically will place explosives to detonate various kinds of barricades to potentially go behind a wall or enter a closed structure. It's a surrogate environment for looking at the impacts of blast exposure because people who partake in breaching tend to do it over long periods of time. So you can study the effects of cumulative exposure to blast and the traumatic events that typically accompany exposure to blast in theater are not present here. Now, there's a lot of work already out there on breaching. We know that it has a deleterious impact on a long host of outcome measures ranging from cognitive functioning to vestibular functioning. Hearing, of course, not surprisingly, because of the impact of blast exposure, musculoskeletal health. There's also been a lot of work looking at self-reports on health and well-being. We see effects there. Now, we have recent evidence from our own lab showing that there are also impacts of long-term exposure of breaching on brain structure. And there's additional work from other labs that have shown similar effects on brain functioning. There's also some very exciting work showing that it's also possible to detect the effects of blast exposure as a function of breaching on blood biomarkers of neurological stress. Now, a question you might want to ask is, well, how do you measure post-concussive symptoms? So there are a number of different ways of doing this because there are a number of different available scales for measuring it. The one that we've been using consistently across studies is the Rivermead Post-Concussive Symptoms Questionnaire. So in the civilian setting, if you believe that you suffer from concussion and you were brought to a clinic, it could be that you might be administered this very specific scale. So I have the scale color-coded in two different sections. So what you see in gray are the three symptoms that are considered to be the immediate symptoms of either concussion or exposure to blast. And those consist of headaches, feelings of dizziness, and nausea and or vomiting. Okay. And then after those initial symptoms, there's a number of other symptoms that can present themselves that can kind of occur over a longer time frame, and it can persist longer. And those are things like sensitivity to noise, sleep disturbance, fatigue and irritation, poor concentration, blurred vision, so forth and so on. So after the person rates himself or herself on this particular scale, then what you can do is you can break it down based on the initial symptoms versus longer term symptoms. You can also score this scale on whether the symptoms are of the cognitive, emotional, or somatic variety. So we administered the scale to a group of operators from CAN-SOFCOM compared to a group of sex and age-matched CAF controls who were not operators from CAN-SOFCOM. And we were able to show that they report, the operators who are exposed to blast during training report significantly higher levels of the longer-term effects of breaching. So the ones that I talked about in terms of sleep disturbance, poor concentration, blurred vision, noise sensitivity, so forth and so on. They also report significantly higher symptoms that fall in a cognitive and emotional domain compared to sex and age-matched CAF controls. Okay, so this particular study showed that the Rivermead is sensitive to the long-term effects of occupational exposure to low-level blast in the context of breaching. But what we did not do in that study is we didn't really have a detailed way of measuring mental health outcomes. So in our follow-up study, we also administered the PCL5, which has been used widely for measuring PTSD symptomatology. So as you can see, this one's got items such as experiencing repeated, disturbing, and unwanted memories of the stressful experience, for example. So in this particular case, we administered both the PCL5 and the Rivermead. And as before, we found that breachers at the Canadian Forces School of Military Engineering report significantly higher levels of scores on both the short and long-term effects of blast concussion as measured by the Rivermead, as well as the cognitive, emotional, and somatic subscales when you assess the Rivermead in a particular way. Now, interestingly, we did not see any kind of differences between breachers and sex and age-matched CAF controls on the PCL5. Okay, so this tends to show that there is something about breaching that is picked up by the Rivermead, which does not impact a PCL5, at least in terms of self-reported PTSD symptomatology. However, I want to emphasize here that context is very important. So what you see here is that breachers report significantly higher levels of post-concussive symptomatology. Those are the two blue bars that you see there. But when you look at the group in terms of whether they have or have not had concussion, you again see differences in terms of the Rivermead. But in addition, you see issues with musculoskeletal function. And then when you parse out the same group of participants based on whether they've been to a war zone or not, again, the Rivermead is sensitive, but here you also see sensitivity as detected by the PCL5. Perhaps not surprisingly, because if you've been actually deployed to a war zone, it is more likely that you might have had experiences that might impact your PCL5 scores. So what we try to emphasize in this particular paper is that when you are looking at post-concussive symptoms as they're measured as a function of blast exposure, it is also important to take other issues into account, such as concussion or war zone deployment. Now, in our current work with CANSOFCOM, we have built on the work that was already done with the previous group of operators from CANSOFCOM and our work at the Canadian Forces School of Military Engineering to do three new things. First, we're trying to develop an empirical framework for a longitudinal health monitoring program for CANSOFCOM, being able to actually track operators over time. The purpose of that work is to see whether we can develop an algorithm that can tell you when an operator is at risk of developing blast-induced mild TBI as a function of their scores on a long host of measures. And finally, it is to inform training-related exposure recommendations for operators based on the findings that we have from people that are currently or have been exposed to blast. So this work essentially has two different arms. One arm is a cross-sectional study. For this particular cross-sectional study, we are comparing operators before and after participation in training exercises that expose them to blast, and we're comparing them to sex and age-matched CAF controls who are not participating in those exercises. In terms of the longitudinal health monitoring aspect of the study, the idea here is to capture CAF members who are going through selection at CANSOFCOM, and if they actually do make it through selection, is to follow them up annually in the course of their careers. And this way we can see whether changes are occurring that are indicative of a greater risk of blast-induced traumatic brain injury, so interventions clinically can take place faster. So at the beginning of this study, we kind of had to do a power analysis to decide how many participants we needed to do a proper empirical work, and we needed 50 operators and 50 sex and age-matched CAF controls. We're deep into data collection at the moment, so we have 47 high-risk population members already that have had exposure to blast, and we've got data from 23 controls. We expect everything to be completed by the end of next calendar year. So my purpose right now is to show you the preliminary data based on this subset of participants from whom we've already collected data to give you an inkling of what might happen by the time the study has been completed. Okay, so here again we administered the Rivermead. So this is where you see the difference in post-concussive symptoms. So this is comparing operators from CAN-SOF-COM to sex and age-matched CAF controls. Okay, so remember the RPQ3 is the short-term effects that of post-concussive symptoms. And what you see here are the long-term effects. So going back, these are things like experiencing restlessness, experiencing fatigue, poor concentration, and so forth. So what you can see again, as we saw with the RPQ3, with data from both Canadian Forces School of Military Engineering and our original group of CAN-SOF-COM operators, that this particular measure is sensitive to the effects of long-term exposure to low-level blast. Now, aside from the PCL5, this time we also added the brief symptoms inventory. This one actually gives you scores on somatization, depression, anxiety subscales. And the idea here, again, was to see whether participants who are showing differences in terms of post-concussive symptoms, whether the same is true for the mental health measures. And as you can see, regardless of whether you're looking at PCL5, the BSI in its totality, or broken down by its subscales, we don't see any kind of differences between operators exposed to repeated low-level blasts in the context of training versus sex and age-matched CAF controls. Okay? So overall conclusions and future directions. So the accumulation of data from our initial set of studies conducted with CAN-SOF-COM operators, followed by the study that was done with the Canadian Forces School of Military Engineering breachers, and what we're doing right now with the high-risk members at CAN-SOF-COM has shown that post-concussive symptoms are sensitive to the effects of repeated exposure to low-level blast. Okay, so as I mentioned, a number of these studies have already been published, and I'll be happy to share them with you if you can't find the papers yourself. Now, repeated exposure to low-level blast up to this point appears not to be related to the mental health outcomes that we have looked at. I certainly do not want to generalize across all of the mental health outcome measures that are out there, but in terms of the PCL5 and the BSI, we have not seen effects. Okay, it is very important to emphasize that it is important ultimately to link whatever difference that you see on any of these empirical measures on job-specific functional targets that you really care about. In other words, it is one thing to say that breaching has an impact on post-concussive symptoms. The next question to ask is whether post-concussive symptoms actually impact an operator's functioning at work. Finally, the overall objective of this work to really advocate for a holistic approach that not only looks at breaching specifically, but looks at the overall environment within which blast exposure happens to have a more comprehensive picture of the impact of blast exposure on health and outcome in CAF members. And with that, I would like to close my session and ask for questions, should there be any. Thank you very much.
Thanks so much, Ocean, for such a great and stimulating talk. This is the exposure to blast injury and its sequelae is such an important issue for the Canadian Forces, and congratulations on all the great work that you've done over the years on this very important topic. So, to start off with our questions is, the first question I would have is, aside from post-concussive symptoms, what other measures distinguish breachers from controls in your research? So how do you distinguish those two groups?
Well, thank you very much for that question. That's actually an interesting question because the answer to it varies in part as a function of the context in which we collected data. So, so far we've collected data from SOF operators in a number of different settings, but we also have data from breachers from the Canadian Forces School of Military Engineering. We've got some kinds of measures that are sensitive to the effects of blast in both contexts and some that are sort of more unique to the specific context. So what I talked about today mostly focused on post-concussive symptomatology because that's really consistent across all three contexts that we've looked at so far. But for example, for SOF operators, we've also collected quite a bit of brain imaging data, and those are typically either of the structural variety or the functional variety. So we've shown that operators who've been exposed to long-term blasts over the course of their careers exhibit lower levels of gray matter in the prefrontal cortex. So that's a paper that was just published. But with these neuroimaging findings, one thing that you're really looking for is how reliable and replicable the effects are. So even though there is this initial finding that there might be structural changes as a function of exposure to blast, I think it remains to be verified in follow-up work that we're currently trying to do with SOF. Another area that we found differences in is also in terms of brain function. So a colleague of mine, Tim Lamb, presented some findings here a few days ago that looked at working memory function when a person is actually doing an effortful task in the fMRI scanner. And his analysis was able to show that people who've had long-term exposure to blast have to recruit additional brain regions for doing an effortful task, even when you keep the level of performance the same. So typically in brain imaging data, we interpret this as some kind of a compensatory mechanism whereby additional recruitment is necessary to perform at the same level. And I think these are really interesting data to look at because they show you that, for example, a person can come to the neuropsych clinic and you can give them some kind of a task to do. And it's not sufficient to only look at performance alone. It's also very useful to collect additional data to see what the underlying reasons for that performance might be.
Great, thank you so much. Another question, this time from one of our participants at the conference. How many of the operators study are female? Is there any reason to expect post-concussive symptoms, health impacts that will be different for women versus men?
Yeah, so this is a very interesting question also. So in terms of the initial studies that we did with SOF, as it so happened, all the operators whom we recruited were exclusively male. So in that particular context, it wasn't really possible to do any kind of gender or sex difference analyses. And then what happened at the Canadian Forces School of Military Engineering was that a very small subset of our participants were actually female. And the issue that we had there is because the sample was unbalanced, we opted not to look at gender differences because of various kinds of statistical issues. We did have some really, really good discussions with people about how to do this better in the future to make sure that we can hopefully kind of explore at least that potential effect in the results that we're seeing.
Great, thank you. Another question. Oh, go ahead, Ocean.
Yes, so I can tell you that we also do quite a bit of work in terms of concussion in civilian populations. So I know that, as you know, the work on blast and concussion kind of go hand in hand because a lot of our instruments are the same. And I know that in the civilian setting, there are different trajectories of recovery from mild traumatic brain injury when you look at gender differences. So there's definitely a lot of room to do some interesting exploration there.
Great, thank you. And another question from one of our participants. Do you recommend clinicians who are seeing patients with post-concussive symptoms be asked about exposure to blast, and how should this answer modify their interventions?
So this also is a very good question. So most of the settings in which we collect data, these two things kind of go hand in hand because the intake questionnaire that we have asks about concussion as well as exposure to blast. But I think a lot of civilian settings is probably going to be an unusual question to ask because it's probably not going to apply to them necessarily. However, I think if you are collecting data from CAF members, I would highly recommend including that in there because you can see not only are the effects on the outcome measures that you're looking at different, I also expect that in cases where you actually have concussion coupled with blast, that the trajectories of recovery might also be different.
Great, thank you. And we have time for one last question, and the question is, what about concussions from sports or interpersonal violence versus blast exposures? Do they present symptomatically differently?
Oh, yeah. So all these wonderful questions. Yeah. So one of the things that we kind of have to correct for statistically in our data set are all kinds of injuries that one might have had that could result in mild traumatic brain injury that are not blast-based. So we look at, for example, things like interpersonal violence, assault on the head, involvement in motor vehicle accidents, if the person remembers ever having been dropped as a child. And what we find in quite a few of our CAF samples compared to the general population data that we have is that those rates of injuries at the outset are already higher. So it's essentially critical to correct for those in your statistics. And then we also have found in our exploration of our data set from both Clinicians School of Military Engineering and from soft samples that depending on the specific kind of injury that you're looking at, the outcomes also vary. So if your focus is on blast specifically, it's critical to correct for all of these things statistically to generate an actual valid model.
Great. Thanks so much, Ocean. Welcome back to this CIMVHR session. So it's my great pleasure to introduce Dr. Ben Dunkley today to this CIMVHR session. He's a well-regarded scientist working out of Sick Kids in Toronto, just down the road from me. And he's going to be talking today about structural and functional brain circuits that are disrupted by repetitive low-level blast exposure, a pilot DTI and MEG imaging study. Take it away, Ben.
Okay, welcome everyone. Thank you very much for attending my talk. It's a great pleasure to be speaking to you all today at CIMVHR Forum. Of course, it's a shame it can't be in person, but I guess that's the nature of the pandemic. Today's talk is going to be on the structural and functional brain circuits that are disrupted by repetitive low-level blast exposure. So this is a pilot DTI and MEG study that I've conducted with Drs. Sean Rind and Mukesh Jetley, great colleagues of mine. Myself, I'm a scientist at the Hospital for Sick Children in Neurosciences and Mental Health, and assistant professor at UFT. And I'm a cognitive neuroscientist by trade, really. I'm interested in understanding, the circuits in the brain and their functions, which give rise to our cognition and our behaviors, and, how that can go awry, how that can become dysfunctional due to either stress or brain injury or whatever. So in terms of today's talk, myself, Benjamin T. Dunkley, in terms of disclosing commercial interests, I'm currently supported by Renita Medical. I have no commercial support, financial support that supported this study to declare, so I have no conflicts of interest to report there. We've done everything we can to mitigate all sources of potential bias throughout this study with rigorous study design and analyses. And by the end of today's lecture, in terms of the learning objectives, I hope you can all understand the impact that an exposure to repetitive low-level blasts has on brain circuit structure as well as function, and how this impacts the mental health status of active service personnel and veterans. So, I'd like to begin by really sort of highlighting the increasing understanding that we have of how repetitive low-level occupational blast exposure really impacts the brain. We know that this repetitive blast can lead to neurological impairment, neurocognitive difficulties, psychiatric comorbidities, and neurocognitive sequelae, which are very similar to mild traumatic brain injury or concussion type events, as we might think of them. And we, increasingly realize that this actually presents quite a big health risk for military members and veterans. And that these symptomatology are really difficult to tease apart from, as I say, repetitive mild traumatic brain injuries. And, these are principally seen in breachers and explosive range staff. And there's been some fantastic studies out there already, showing some of the deficits and dysregulation that this group can present with. So today I'm going to be talking about a preliminary study that, we've been running here at Sick Kids in collaboration with the CAF, where we've looked at the mental health status and structural and functional neural circuits in CAF personnel with exposure to repetitive low-level blast. So in terms of our patient demographics, participant demographics, rather, I should say, to date we've recruited 24 CAF members, 9 with repetitive low-level blast exposure, 15 control participants, who will act as controls, who've actually been exposed to operational stress. Similar military histories and exposed to kind of stressful environments, as you might expect, but not exposed to persistent repetitive blast. So we've got 9 blast exposed and 15 controls to date. They've been matched on age. They're in the early mid-40s, and we've got pretty much roughly a balanced sex ratios at the moment. Now, we assessed the mental health status. We looked at PTSD, anxiety, depression, as well as mild traumatic brain injury symptoms, and these were evaluated using the PCL, the GAD-7, the PHQ-9, and sports concussion assessment tool, version 2. We also acquired some imaging data. So first of all, we acquired DTI, diffusion tensor imaging, which gives us beautiful measures of the tractography of the brain, the white matter pathways, and we used a 6-direction protocol there. We also acquired Magnetoencephalography resting state. So MEG, as we call it, is very similar to electroencephalography, EEG, which some of you might have heard of, and this measures neural activity, neural firing in the brain, which is generated by our internal thoughts and feelings, which is really just driven by the electrochemical action of the brain. So all that electrical activity generated during our thoughts and feelings we can measure with MEG, and we used MEG in this case to record that. So we get a really nice balance of structural indices from DTI and functional brain activity through MEG. So I'll talk a little bit about those now, or after our mental health status findings. When we compared the groups, we found that there were no significant effects, no differences in the mental health status of our operational stress exposed to blast exposed participants. However, there does seem to be a large amount of variance, really in the control group, where there were a few outliers really driving sort of like the mean measures in the control group, as you can see here, where we have the mean in the circles and the median in the squares. There does seem to be this disparity, so there's a lot of skewness in this one group, which we will have to look into. But we did see kind of elevated rates of anxiety, depression, PTSD, and concussion symptoms in all the groups. Self-report, they reported this. Certainly, there seemed to be increased symptoms of PTSD in the blast exposed group, which seems quite a bit higher than our control group when looking at the medians at least. So, once we have our full cohort imaged and assessed, we'll revisit this. But, currently no differences in the mental health status or the reporting of concussion symptoms, differences between those groups, we haven't yet detected. So in terms of the imaging, as I said, we've looked at DTI, diffusion tensor imaging, and magnetoencephalography. Now, DTI gives us this beautiful structural measure of the brain. We can measure the white matter pathways, the tracks that connect the different areas of the brain. And it does this through looking at the diffusion of water molecules along these white matter pathways, these diffusion gradients. And with that, we can kind of get an index of the integrity of these white matter pathways. Now, there's a lot of evidence out there that, this white matter is particularly susceptible to concussive injuries or subconcussive cumulative brain impacts, potentially blast exposure. So we use DTI sequencing, which is just an MRI sequence, really to look at that in this group, and it gives you this beautiful picture, as you can see here, which is like the static wiring of the brain, and transfers information around the brain. Now, with MEG, we can look at something very different. DTI gives us a static measure of the brain and those pathways, whereas MEG measures really the moment-to-moment fluctuations, the highly dynamic nature of the brain. With all those neurons firing, those synapses firing, this is what we measure with MEG. So they're two complementary methods. They measure very different things, but one tells us about the structure, one tells us about the function, one is static, one is dynamic. But MEG measures this dynamic component, those neurons firing, which underlie all our thoughts and feelings. Now, often this is referred to as brain oscillations, brain waves, and it's a really powerful technique to, I think, understand the dynamics, this highly variable brain states that we have from moment to moment, and it can be thought of as kind of related to functional magnetic resonance imaging, but fMRI really measures like the blood oxygenation, the hemodynamics of the brain, so it misses out on this really fast synaptic firing, that neural activity, which we're interested in. So we've used these complementary techniques. Now, when we look at white matter in the brain after this persistent blast exposure, we find that there's decreased fractional anisotropy. So that means that there's a decrease in the movement of water molecules along one gradient, and there are increased radial diffusivity and mean diffusivity across major tracts in the brain. What does that mean? It basically means that there's damage to this white matter, where kind of water seeps out of those white matter tracks. They diffuse along against a gradient that we might not expect. So it basically points to, not definitively, but suggests that there's white matter damage. Certainly across wide areas of the brain in terms of these deep white matter tracts, these pathways that are moving information around the brain. We see this decreased FA and this increased RD and MD. So there does seem to be white matter dysregulation, certainly after this persistent blast exposure. And when we look at the MEG data, this is a very busy slide, so I'm just going to break it down. The key take-home message is that the speed of brain activity kind of slows down. We have different speeds of brain activity going on, and these different speeds subserve different psychological processes. So when we look at slow neural activity in the brain, 1 to 3 hertz, 1 to 3 times a second, you can see this characteristic patterning in the top left in our control group, which is indicated by greater intensity in our blast exposed group here in the 1 to 3 hertz range, this slow activity. And there's significant differences that they're expressed in this right temporal pole area, as to whether that's a particular susceptibility to kind of the way they are facing a blast wave. That's an open question at this point, but it definitely seems to be that there's this temporal pole area, which is an area involved in memory and functioning. That seems to be susceptible and shows changes in the blast exposed compared to our control group. Now, when we look at very fast brain activity, in this 15 to 25 hertz rhythm and above. So this is activity in the brain that really controls the excitability, underlies, again, a lot of our thoughts and feelings, memories and what have you. You can see this characteristic patterning once again on the bottom left in our controls, and this seems to be greatly diminished across many areas of the brain in the blast exposed. And then when we look in the contrast here, in this third column on the bottom row, you can see this dark blue hue indicates that it's greatly decreased in blast exposed. And these red color maps here indicate a significant difference. So all of these frontal regions, these regions that control our executive functioning, our memories, cognitive flexibility, our behaviors, this fast activity in the brain seems to be greatly diminished. But, the take-home message from all of this here, and I realize that, there's quite a lot to digest, is that brain activity slows down. There's more slow activity in the brain and there's less fast activity in the brain. So what does that mean really? There's changes in excitability and inhibition in the brain. These circuits are disrupted. These are completely otherwise invisible measures that we wouldn't see with fMRI or DTI. So, you get that white matter structural change as well as changes in rhythmic brain activity, those neurons firing, and the excitability of synapses, which is expressed here. But again, the take-home message is that there's this slowing down of brain activity, which seems to be due to this exposure to persistent, repetitive, low-level blast. With MEG, we can also look at communication within the brain, and again, seems to be a lot of information to digest here. But just to break it down, on the left we have this. This square here that we call a matrix. Now, what does that remind you of? To me, it reminds me of a QR code. QR codes are everywhere these days with the COVID pandemic. But this is almost your brain's QR code. Everyone has kind of like a fingerprint of brain activity. Everyone's as individual. And this is the characteristic patterning of connectivity we see in the brain. And this is just the group averaged of the controls on the left and the blast exposed in the middle. But each of these dots in this matrix indicate a connection in the brain, a pathway of how different brain areas communicate. And you'll see straight away, it is quite visually intuitive that it seems diminished in the blast exposed, and here on the right, we have a subtraction of that matrix. And you can see these blue dots indicate the connections in the brain that are dysregulated and disconnected in blast exposed, right? So, these fingerprints of the brain that I like to call them, certainly even just visually show differences between the groups. And as soon as we, look at that statistically and image it in space, you can see that this disconnectivity appears across many areas of the brain, right? So there's deficits in communication between how one area talks to another, and this is really quite striking in the blast exposed group. So in terms of summary, exposure to operational stress as well as persistent low level blast certainly seems to result in mental health challenges. Self-reported symptoms increased in PTSD, persistent post-concussive symptom, depression, anxiety. That they're often comorbid. But in the blast exposed group, it seems that white matter is particularly susceptible to dysregulation. There are changes in the white matter integrity that we see. For those of you that do neuroimaging, there's reduced FA and increased RD and MD, which is consistent with edema, necrosis, and demyelination. When we look at the MEG data, we find that there's this slowing of rhythmic neural activity in the brain, so it changes your patterns of brain waves. We see a slowing down of this neural firing and neural activity, as well as an inability for many different regions of the brain, within hemispheres and across brain regions. There's dysfunctional communication, and there's deficits there as well. Now, to finish up, I would like to highlight that this is really actually consistent with some of the previous studies we've run, showing that when we can compare those with mild traumatic brain injury with controls, we see this similar pattern in our blast compared to OS controls, suggesting that there are deficits in neural functioning and even kind of similarities with some other groups' work looking at neurodegenerative disease, including early onset dementia. So with that, I'd really like to thank collaborators and funders, both past and present, my co-authors on the study, as well as all our fantastic funding partners for their wonderful support during this. And finally, there's the references that are presented in my talk. Thank you very much.
Thanks so much, Benjamin. That was a great and very stimulating talk, again, about one of the most critical areas of research that is ongoing for serving and Canadian Forces veterans. So, a couple of questions that have come up is, how might your work inform treatment and care of those with brain injuries? And that is, or what are the practical implications of your current research?
Yeah, great question, Andrew. So I think, hopefully in future we're going to move to image-guided therapy. There are a lot of new and emerging techniques, as you might be aware, like psychedelic interventions, as well as brain stimulation. There's a huge amount of research and ongoing clinical work now into like deep brain stimulation, VNS, transcranial magnetic stimulation, transcranial electric. And I really think in future, you should be able to derive kind of individual personalized maps of where this neural dysregulation occurs. And we know that, things like transcranial magnetic stimulation, transcranial electric stimulation, which work on this repetitive stimulation of the brain, could essentially use MEG maps of an individual's brain to target particular brain regions that might show pathological slowing. We certainly know from others' work, as well as a little bit of ours, that this slowing occurs in regions where there's this grey white matter boundary where shearing occurs. There's this demyelination, deafferentation. You could potentially target that bit and promote neuroplasticity, neural repair. We know that there's adaptive oligodendrogenesis, changes in white matter plasticity, and we'd expect, hypothesize this to be accompanied by changes in neural firing and hopefully recovery and resolution of symptoms.
Great. The question from the audience is, so how might this compare with non-blast mild TBI and other neuropsychiatric challenges such as post-traumatic stress disorder?
Yeah, I mean, superficially, when we compare them side by side, and we've looked at a group with non-blast mild traumatic brain injury, a single incident, mostly sports, but it was actually a bit mixed mechanism, sort of motor vehicle accidents, as well as falls, some assaults. On the surface, they actually appear quite similar. This slowing down of neural activity, this functional disconnectivity between brain regions. So it does appear somewhat similar to what we see there. We haven't done a formal quantitative comparison yet, but we will do. Certainly in PTSD, we published a paper recently showing that the symptomatology overlaps a lot across these groups, across NTBI, across BLAST, across PTSD, as we've seen to some degree. Anxiety and depression is often comorbid. But using MEG, looking at neural indices, we can tease them apart using AI and machine learning quite well. And we actually see them differentially expressed. We actually find that there's too much high-frequency gamma in PTSD seems to be one of the characteristic signatures, right? Which, it points to increased excitability, and this is kind of some of the reverse that we see in our both BLAST and non-BLAST MTBI groups. So, we're hoping that despite a lot of overlap in terms of the symptomatology, that we can begin to potentially use this to kind of triage people and show that, they might benefit from one therapy over another, and predict treatment response in that regard.
And further to that, and do the actual structural brain circuits themselves, do they these changes in them, do they mediate the functional dysregulation that we see?
We believe so, yeah, because the structural integrity of these white matter tracks essentially mediate the conduction velocity of the electrical signals between brain areas, and that allows these neurons in disparate brain regions to synchronize, which is what facilitates these areas communicating and talking with one another. So that degradation in the white matter, we think plays a big role in causing that desynchrony, that disconnectivity, that deficit in communication. Once we've collected a full cohort, we'll kind of do a data fusion study. We'll look at the correlations between the actual white matter pathways and the MEG connectivity in a bit more detail. At the moment, it's just side-by-side comparisons, right? Qualitative visual assessments. But we do think that it mediates the ability for different brain areas to communicate that we measure with the MEG, just there.
Okay, thanks so much, Benjamin. We really appreciate your talk. Introduce our next speaker, who's Massimo Cao from the University of British Columbia. He is presenting for Nabil Ali Mohammed, also from UBC, and they're presenting on a very challenging topic, and they've introduced a very novel therapy to try and deal with one of the biggest problems in trauma care, which is non-compressible intra-abdominal hemorrhage, and how do you control bleeding without a surgeon around. And so they've been working on this very promising technology, and it gives me great pleasure today to introduce Massimo Cao from the University of British Columbia.
Hi, I'm Massimo. I'm a PhD candidate in the lab of Dr. Christian Kastrup at UBC, and the title of my presentation today is Minimally Invasive Delivery of Counterflow Hemostatic Powder Extends Survival in a Model of Non-Compressible Truncal Hemorrhage in Swine. Before I start my presentation, I would like to acknowledge that I'm coming to you today from the ancestral, traditional, and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh nations. Here are my disclosures. I want to take this opportunity to thank CIMVHR for their enormous support, which made this project possible. The learning objectives for my presentation are to identify shortcomings in the current management techniques in non-compressible torso hemorrhage, to list management techniques currently in use and in development, and to understand the counterflow drug delivery platform and its efficacy in managing hemorrhage. Here are my references. Non-compressible intra-abdominal hemorrhage can currently only be addressed by surgery, and this is what we see in animal models of non-compressible abdominal hemorrhage as well. In this swine model of non-compressible liver injury, animals that receive only standard of care fluid resuscitation and intravenous tranexamic acid have poor survival at 3 hours. There will be more on this later on. So the major challenge of my work is, as I mentioned, non-compressible abdominal hemorrhage, which is a very common cause of preventable death on the battlefield. It is also a very common cause of death in civilian trauma, as up to 40% of all deaths worldwide due to hemorrhage in the civilian sector are due to this type of hemorrhage. This type of hemorrhage is very difficult to manage because the bleeding site can be inaccessible and lie deep within body cavities, and there may also be several different injuries. The only management for non-compressible abdominal hemorrhage is immediate surgery, but this is not always possible, such as in situations where the casualty is in remote austere setting or there's no air superiority available. Therefore, strategies which extend survival in the pre-hospital environment are needed. There's primarily 3 interventions which have been used to manage non-compressible intra-abdominal hemorrhage. And these are resuscitative endovascular balloon occlusion of the aorta, better known as REBOA, an abdominal aortic and junctional tourniquet, AAJT, and these are quite well known and have been around and are used where possible to manage abdominal hemorrhage. Recently, intra-abdominal foams, such as rescue foam, have been developed, which are directly injected into the abdomen, where they expand and apply pressure within the abdomen to create tamponade and stop bleeding. So while these strategies are useful for buying time and allowing patients to get to surgery, they have major limitations. They can only be used for 1 to 2 hours before deadly adverse effects occur. These effects include distal ischemia and abdominal compartment syndrome, which can lead to limb amputation and multiple organ failure. Furthermore, Reboa and rescue foam are very challenging to administer in the pre-hospital environment because advanced technical skills are needed to place these devices. Hemostatic agents are highly effective at treating many types of hemorrhage, such as hemorrhage from extremity wounds. But in non-compressible intra-abdominal hemorrhage, these agents are not effective. They cannot be transported to the bleeding site at high enough local concentrations for them to be effective. This is due to high flow rates and pooled blood, which flush out these agents and prevent sufficient contact of these agents with injured organs and vessels. There are also many difficult anatomical areas that these bleeds may originate in, which makes this problem even worse. Management of non-compressible abdominal hemorrhage would therefore greatly be improved by specifically delivering these agents, hemostatic agents, to bleed sites within the abdomen. And these agents would be compounds and agents such as thrombin, which is a powerful procoagulation enzyme, or tranexamic acid, or TXA, which is an antifibrinolytic agent used to stabilize blood clots. The hypothesis we are currently testing is that enhancing the transport of hemostatic agents will manage abdominal hemorrhage, and this is being done in collaboration with Lieutenant Colonel Andrew Beckett and Dr. Hugh Semple and Catherine Ten at Defense Research and Development Canada. Counterflow is the technology that we have developed at UBC, which is able to deliver drugs through pooled or outward flowing blood so that these drugs can better target the wound sites. Counterflow consists of self-propelling microparticles that can be loaded with a therapeutic cargo such as a small molecule or an enzyme. The microparticles are mixed with an organic acid, and when this mixture contacts blood or any other aqueous solution, a chemical reaction occurs and CO2 is generated. This generation of CO2 propels and disperses the microparticles and the cargo deep and throughout wounds, even against the outward flow of blood. In the bottom left image, an electron micrograph shows how the calcium carbonate microparticle is porous, which makes it very suitable for adsorbing small molecules or enzymes. Loading counterflow in the bottom right onto a gauze, which can be packed into wounds, such as what is currently done with H&H gauze and combat gauze, leads to an increased delivery of hemostatic cargo throughout the wound and makes it a very effective agent to stop bleeding. The balanced chemical reaction for this equation for this reaction is shown here. The source of protons in this system is protonated tranexamic acid, which is also a potent antifibrinolytic drug, a clot stabilizer. Counterflow's components, calcium carbonate and carbon dioxide, are safe, bioabsorbable, and soluble in blood, wounds, and vessels. To test this agent, we used the swine model of junctional hemorrhage created through a femoral artery injury. This is a standard model for developing new hemostatic bandages, and hemorrhage is quickly lethal if left untreated. When the current military standard combat gauze or the current surgical standard, which is thrombin gauze, were packed into wounds, survival was poor. But when self-propelled thrombin was used to pack wounds, survival was 100% at 3 hours. Later on, we also went on to show that self-propelled tranexamic acid on its own also led to a 67% survival rate. In more recent work, we aimed to test whether counterflow loaded with thrombin and tranexamic acid could be delivered into the abdomen percutaneously using a spray device and a catheter. This figure shows that we were able to implement a minimally invasive procedure that requires ultrasound to visualize free fluid within the abdomen that represents the hemiperitoneum. The catheter is placed into the hemiperitoneum using the standard Seldinger technique without any major incision being needed in the abdomen. The spray device loaded with counterflow is then connected to the catheter, and counterflow is delivered into the abdomen where it reacts in blood and disperses calcium carbonate, tranexamic acid, and thrombin. To test if this delivery system could be effective in non-compressible abdominal hemorrhage, we used the swine model based on a liver injury. We performed a control hemorrhage in which blood is aspirated from an artery until the mean arterial pressure drops below 50 millimeters mercury. We then perform a midline incision and cut out a 10 centimeter by 3 centimeter rectangle from the left medial lobe of the liver to create hemorrhage. We also gave animals 1 gram of intravenous TXA because this represents the standard of care. Bringing back the figure that I showed at the beginning, what we found was that counterflow could manage non-compressible abdominal hemorrhage and extend survival, which is exciting. Median survival time was 0.8 hours in the standard of care fluid resuscitation group, and it was 2.5 hours in the counterflow group. Delivery of counterflow via the spray device was associated with a safe increase in intra-abdominal pressure that did not reach the pressures used in laparoscopy, indicating that this procedure has a low risk of complications such as abdominal compartment syndrome. Now, although these studies were short, we did not see any acute adverse effects from the delivery procedure or any signs of thrombosis from counterflow when tissues were examined post-mortem. This is consistent with previously published data from other large animal studies showing that counterflow does not cause thrombosis. However, further studies are needed to fully rule this out. We also found that counterflow is able to disperse throughout blood within the abdomen and create large clots, even away from the injection site. Counterflow was incorporated into these very strong clots that could not be pulled apart by hand. These clots were very rich in fibrin, and these are likely formed by the thrombin as well as the calcium that counterflow delivers. In conclusion, counterflow is a promising new agent for managing non-compressible intra-abdominal hemorrhage. It has several expected advantages. It can be administered by a non-surgeon physician or a highly trained medic. It also does not exert sustained pressure. There's a reduced risk of ischemia and compartment syndrome. The components of counterflow are also resorbable, meaning that when it is no longer needed, it is broken down by the body and does not commit the soldier to a laparotomy. In conclusion, I'd like to acknowledge our collaborators as well as all of our funding sources that made these discoveries possible. And I'd be happy to take any questions that you have. Thank you.
Thanks so much for presenting this, Massimo. It's great to see our work being so ably presented. And there's a question coming up from the audience here is, could you comment on the risk of thrombosis in animals, given that thrombin is a very powerful clotting agent and it's being applied to open bleeding vessels?
Definitely, that's a great question. So thrombin would be inhibited by its inhibitor in blood, which is antithrombin, if it does manage to reach systemic circulation. And the concentration of antithrombin that circulates in the blood is much higher than the concentration of thrombin, which leads us to believe that this agent would be safe. We've also done multiple recovery studies in animals where we've kept them alive for several days after administering counterflow, and we've looked at D-dimer concentrations, as well as we've done tissue analysis with histopathology, and we've never seen any signs of thrombosis. But as I mentioned, this is the first use of counterflow for intra-abdominal hemorrhage. And so we will be looking closely at whether there's potential risk for thrombosis.
Okay, thanks for that. Another question that came up is, do you think counterflow is going to be useful in other types of non-compressible hemorrhage, such as major vessels like the aorta bleeding or like the liver bleeding? And are you guys going to include any more studies on this?
We are planning more studies testing counterflow in multiple different types of non-compressible abdominal hemorrhage. I do believe that counterflow could be effective in these other types of injuries based on the way it acts. So if we're able to deliver it into the abdomen, it will be able to disperse effectively to sites of bleeding. And because of the high concentration of thrombin and TXA, as well as all the calcium, I think that it could have some efficacy in managing even the most severe bleeds, such as the aortic bleeds.
And another question is, have you ever tried it in any other types of hemorrhage models, like bleeding from the skin or superficial wounds, or like bleeding from the groin? Have you tried it anything like that?
Yeah, so we've tested counterflow on gauze in a variety of different animal models. We've tested it in a swine model of junctional hemorrhage from the femoral artery. We've tested it in sheep as well, in the carotid artery, as well as a nasal turbinate injury. And more recently, we've also tested counterflow for arterial upper gastrointestinal bleeding. And in all cases, counterflow is performed superior to the standards of care, which kind of set the stage for us to test it in this extremely challenging, complex problem, which is abdominal hemorrhage.
One last question is, somebody's asking here, what if, for a subdural hematoma or bleeding in the brain, could you inject it into the brain?
I like to think it might be possible. I don't think I know enough to be able to medically to be able to comment on that. But I do think that the components of counterflow are very safe and currently used clinically. So I don't, at the moment, see any reason why it wouldn't be something we could try.
Okay, thanks very much, Massimo, for your presentation. Our next speaker is Dr. Henry Peng from Defense Research Development Canada, and he's going to be speaking to us today about freeze-dried plasma for casualty care and COVID-19 therapy. And I have to say, I've been working with Henry for a long time, and he's a great defense scientist and has really brought up the standard of research within the area of combat casualty research. So take it away, Henry, and thanks again for presenting today.
Hi, everyone. My name is Henry Peng. I'm a defense scientist at DRDC, Toronto Research Center. I will talk about some of our work on freeze-dried plasma, from casualty care to COVID-19 therapy. I have nothing to disclose. I'll start with discussion about combat hemorrhage and resuscitation, followed by our effort to develop Canadian freeze-dried plasma, or FDP. I will then talk about convalescent plasma and its corresponding FDP for COVID treatment. Finally, I'll present some of our analysis for the hemostatic profiles of both Canadian and convalescent FDP in comparison with their initial fresh frozen plasma and convalescent plasma. Here is the list of main references for my presentation. Those highlighted in red are our own publications. As you may know, hemorrhage is the leading cause of death on the battlefield. Damage control resuscitation with blood products is recommended at the earliest possible time after combat injuries. As a result, dried blood products such as freeze-dried plasma are particularly useful for casualty care, given their logistic advantages over liquid blood products, such as long shelf life, even under field environment, no requirements for cold chain and thawing device, high portability, and reduced time to transfusion. Currently, there are 3 FDP products on the market. The French one is produced from 10 carefully screened and monitored donors. German FDP is produced from single donor, quarantined for more than 4 months. The South African one is made from hundreds of donors. All these products are manufactured in glass vials, which can be broken easily, especially in the battlefield. Both French and German products have been used by military for combat care, but they won't be approved by Health Canada due to the risk of prion disease transmission. Therefore, there is the need to develop Canadian FDP. The diagram shows the production process using a freeze-drying system from Temuro BCT company. Briefly, each unit of FDP is manufactured from Canadian-sourced plasma collected from 10 healthy donors in a plastic bag. The product can be reconstituted in water within 2 minutes for transfusion. As it's produced in a plastic bag, there's no glass bottle breakage. The product is more rugged and suitable for remote, austere settings. While we are working on the project, we were hit by the global pandemic, which has caused millions of deaths up to date. Even with the vaccination, we are in the fourth wave with thousands of daily infections due to highly contagious Delta variant. There have been tremendous global efforts to find an effective treatment for COVID-19. Convalescent plasma has drawn lots of attention and being widely studied. The treatment involves transfusing convalescent plasma, which is a cellular portion of blood collected through a plasmapheresis process from individuals who have recovered from COVID to people who are infected or at risk of infection. The plasma donors should have developed an effective antibody response to the virus. The confirmed immunity is immediate, but may be short-term. Other limitations could be the batch-to-batch variability in the antibody levels, as well as the same requirements for the standard blood transfusion in bleeding patients. Built on the initial work on Canadian FDP, we have produced convalescent FDP, which would have several advantages over convalescent plasma used in clinical trial. First is the lung stability, which would allow stockpile and easy use in developing countries and deployed troops during future pandemic. Secondly, as this is a pooled product from 10 donors, it would standardize neutralizing antibody activities compared to single donor convalescent plasma. Thirdly, convalescent FDP can be reconstituted and transfused in a smaller volume to get a higher antibody level and avoid volume overload. It should be noted that in addition to the antibody-based inhibition of viral replication, there are other important actions exerted by convalescent plasma useful in fighting COVID, such as immunomodulatory and anti-inflammatory activities. Here are some laboratory methods we use to characterize both Canadian FDP and convalescent FDP. First, we use a road analyzer to measure global hemostasis from the beginning with coagulation to the end with fibrolysis based on different parameters, including clotting time, alpha angle, maximum clot strength, and lysis index. We also use stereoanalyzer to look at specific factors in blood coagulation cascades. The multiplex immune system was used to measure immunological profiles, including antibody level and virus neutralization activity. This slide shows hemostatic profiles of 3 preparations of FDP reconstituted in water in comparison with their initial fresh frozen plasma. The left figure shows the global hemostasis as measured by different Roten parameters for coagulation and fibrolysis. The right figure shows the plasma levels of fibrinogen and factor V, which are 2 most important coagulation factors for hemostatic resuscitation in trauma. First, there were no differences in global hemostasis and specific clotting factor activities between the fresh frozen plasma and its corresponding FDP, suggesting the hemostatic components were preserved during the freeze-drying process. In addition, there were no differences among the 3 preparations of reconstituted FDP stored under different conditions before being frozen at -80. These are the samples reconstituted and immediately frozen at -80, or first stored at 4 degrees for 24 hours before being frozen, or stored at room temperature for 4 hours before being frozen, suggesting short-term stability of FDP after reconstitution. This slide shows hemostatic profiles of convalescent plasma and its FDP in comparison with healthy control. The left figure shows the global hemostasis as measured by different Roten parameters. The right figure shows the plasma concentrations of fibrinogen and D-dimer, which are 2 most important biomarkers for coagulopathy in COVID. First, both convalescent plasma and its FDP show similar global hemostasis and plasma levels of specific biomarkers for coagulopathy in COVID patients, again suggesting the hemostatic components were preserved during the freeze-drying process. In addition, both convalescent plasma and its FDP are comparable to its pre-COVID healthy control, suggesting recovery of COVID patients to normal hemostasis. We also compared antibody level and neutralizing activity of convalescent plasma and its FDP, which will be presented in details by my colleague, Dr. Sean Ryan, in the forum poster session. In summary, we have shown both Canadian and convalescent FDP are equivalent to their corresponding plasma sources in terms of hemostatic profiles, with several logistic and therapeutic advantages. Clinical trials need to be conducted to evaluate their safety and efficacy for casualty care and COVID treatment. We are planning for a clinical trial of Canadian FDP in bleeding patients under Health Canada Innovative Technology Assessment for licensing the product. We will continue our laboratory studies of clinical trial samples for further understanding hemostatic and immunological responses in COVID patients. We will publish our findings in open literature and DRDC reports. I'd like to thank Lieutenant Colonel Andrew Beckett for his tremendous support and guidance. I'm also grateful to our collaborators at Canadian Blood Services. Last but not least, I'd like to thank my colleagues at DRDC for their support from different perspectives, especially during these challenging times. I'll stop here and be happy to answer any of your questions. Thank you for your attention.
Thanks so much, Henry. It's great to see our work being presented so well, and the results have just been amazing coming out of your lab. A question from the audience is there any study documenting the effectiveness of convalescent plasma against COVID-19? So I guess they're asking, about, are there any clinical studies that's shown as a benefit? And maybe you can talk about early use of convalescent plasma versus patients in the ICU.
Yeah, thank you for the question. So actually, we did a systematic review on convalescent plasma for COVID treatment. So basically, as you may know, there are a lot of different studies, but most of these studies are either case series or randomized control study with very small sample size. So with different outcomes. So some did show, the efficacy and of the convalescent plasma for convalescent plasma for COVID-19 treatment, but some show no efficacy. So there are some, I believe, some recent studies with larger sample size. Basically, but they are still not consistency. So basically, it seems that the convalescent plasma would be more effective for early infected patient and basically with mild COVID-19, and also the antibody titer in the convalescent plasma is a key factor. So it has to be high, the convalescent with higher antibody level.
All right, thanks, Henry. And you spoke about the Canadian freeze-dried plasma, but have you ever taken the time to compare it with the French lyophilized plasma or the German Red Cross's Lyoplas freeze-dried plasma product?
It's a great question. Yeah, it's something we are considering to do given the similarities of our FDP to French FDP, both produced from pooled plasma of healthy donors. The variability, the batch-to-batch variability in hemostatic properties would be less compared to German FDP produced from single donor.
Okay, thanks so much, Henry. And have you ever looked at the costs that are between the freeze-dried plasma and frozen plasma in Canada? Have you ever done a cost comparison?
We haven't done a very deep, in-depth analysis, but based on the literature, the German FDP is twice cost twice than the single donor plasma. So we assume basically our FDP would be costly than initial fresh frozen, but given the ability to save lots of plasma waste in our hospitals, actually it would be more cost effective. Yeah, that's something we need to do in depth for our analysis.
Okay, great, Henry. Thanks so much. Hi, everybody. We're back with CIMVHR Session C. This part of the talk, we're going to be moving into something that a lot of Canadians will understand is about cold weather injury and cold weather stress. First up is Dr. Wendy Sullivan from Defense Research Development Canada, where she's a defense scientist, and she's going to be speaking about cold weather injuries during Canadian Forces Arctic operations. Take it away, Wendy.
Thank you for attending this presentation. The title is Cold Weather Injuries During Canadian Armed Forces Arctic Operations. Hi, my name is Wendy Sullivan, and I'm in the Operational Health and Human Performance section at Defense Research and Development Canada, Toronto Research Centre. We have no relationships with commercial interests. This program has received no financial support or in-kind support from any commercial organization, and I have not, nor have my colleagues, received payments and funding from any organization whose products may be mentioned. We have no bias. This presentation will focus on one of the health threats of Arctic operations, and that is cold weather injuries, or CWI. This presentation will explain the importance of active medical surveillance during cold operations. As per Canada's defense policy, strong, secure, and engaged, there's an acknowledgement by our government that there is an increasing interest in the Canadian Arctic due to climate change, changes in technology, and increasing accessibility in the Arctic. Arctic sovereignty is the Canadian Armed Forces goal in the Arctic, and they are focused on enhancing mobility and reach in the north. However, the Canadian Arctic in the winter is not always a friendly place, and the average temperature ranges in the -30s and -40s, and can even go down to -60s with the wind chill. This project, titled Health Protection Factors During Arctic Operations, was conducted from approximately January 2016 until March 2019. The objective of this project was first to collect baseline data on health threats and performance decrements related to Arctic operations. Second, to identify the key issues, challenges, and limitations of current CAF medical treatment, medical evacuation procedures, and human performance challenges. Third was to identify future research priorities. Today, I'm going to discuss some interesting findings from this project, including the high number of cold weather injuries sustained on these 7 Arctic exercises, and that a significant number of these injuries were only discovered with active medical surveillance. What is active medical surveillance? Active medical surveillance is when the troops are examined after the exercise by a member of the medical team. The focus is looking for cold weather injuries on hands, feet, and face. Passive medical surveillance is when cold weather injuries are being self-reported during the exercise or operation. Active medical surveillance was first conducted during exercise Arctic Ram in 2016. During that exercise, we discovered that there was a significant number of cold weather injuries occurring that were not being reported, diagnosed, and therefore treated. This is concerning because there's research indicating that previous cold weather injuries can be a risk factor for future cold weather injuries. This could have a negative impact on capability and, depending on the severity of the injury, potentially long-term health consequences. This slide shows you the total number of injuries in each exercise or operation from 2016 to 2019. We excluded the 2017 data that we collected on exercise Norix and Nunavut, as there were challenges with the overall data collection, and as a result, we were missing some data. The dark blue navy portion represents the number of injuries that were reported under passive medical surveillance, a system that relies on self-report and observation, potentially from a medic or a buddy in the field. The light blue shows how many more injuries were detected through active medical surveillance when the medical team took an active role and made a third duty to examine each member when they returned from the field. This slide shows the number of members injured in the first column, and the next three columns are a breakdown of the types of injuries: frostbite, frost nip, and hypothermia. What you will notice is that there are more injuries or cases of injuries than members. This is because a number of people in each exercise had more than one injury. For example, you might have been diagnosed with hypothermia and frostbite on your feet, and this would count as two separate cold weather injury cases. Overall, the average cold weather injury rate on the three exercises or ops that we were successful in collecting both active and passive medical surveillance was 32%. The severity of these injuries varied from mild frost nip to frostbite blisters. There were no amputations that I'm aware of. In 2018, during the active medical surveillance data collection, the research team observed that a number of the troops did not even realize that they had a cold weather injury. At the end, the troops came in, they were looked at by the medical officer or medic, and they noticed for the first time then that their toes were white or the bottom of their foot was white. So in 2019, we added a question to the cold weather injury survey, and we asked them that if they didn't seek medical attention, were they aware of their injury? We found of the 76 members who answered that survey question that over half, 54%, did not realize that they were injured. This graph shows a breakdown of the location of frostbite or frost nip on the various exercises. As you can see, frostbite on the nose was the most common injury location. There was a spike in 2019 during exercise Guerriere Nordique with 41 frostbite cases. This may be due to a new piece of face protection that many of the troops are now wearing, as it helps keep your goggles from fogging. One medical officer did note that that piece of equipment has a piece of metal in the nose, so it could be contributing to frostbite on the nose, but more research is required. Hands and fingers were the second most common injury, and this is due to a number of factors, one being that many of the troops have to remove their mittens and or liner gloves to do any sort of task that requires a fine level of dexterity. We also found that mittens are the most common piece of issued clothing that's replaced with commercial equipment. This can be problematic, as some of the commercial mittens that are personally purchased by the troops are not protective enough for the Arctic environment. Cold weather injury surveys collected during Opna Nalevit and Exercise Norix 2019 also captured mechanism of injury data. This was a section where members and or the medical officer were able to document what they believed caused their injury. This is important information as can help identify causes of cold weather injuries that can potentially be addressed by better equipment or training and therefore prevented in the future. Hypothermia was attributed to a number of factors, such as an active workplace, followed by rest, wet clothing, and equipment that overall was just not protective enough. Of the members who were diagnosed with injuries on their feet, 80% of them wore the issued mucklucks, 65% indicated they were wearing the wrong size boot, and that can lead to cold weather injuries. 60% noted they had wet socks and liners, 40% indicated they were previously diagnosed with frostbite on their feet, and 20% just found that their boots were not protective enough for that environment. Members who were diagnosed with cold weather injuries on their hands, 56% wore the issued mittens, and many believed that their injury was caused by dressing down to their liner glove or their bare hand when they required more dexterity. Wet liners and long snowmobile patrols were also mentioned as contributing factors for these injuries. For members who were diagnosed with a facial cold weather injury, 65% were on the nose, and they were mostly attributed to inadequate face protection, wet, frozen clothing, and the snowmobile patrols as well. The cold weather injury data collected in 2016, 2018, and 2019 found that many cold weather injuries were going undetected without active medical surveillance. Implementing active medical surveillance during all cold weather operations will help to ensure that all cold weather injuries are diagnosed, documented, treated, and followed up care is received if required. Will also help to ensure that future operations are adequately stocked with the appropriate amount of medical supplies and medical equipment to treat these injuries. Documenting all cold weather injuries and understanding why they are happening can help prevent them in the future. This will also improve the health of the troops deployed to the Arctic and enable them to be more effective in the field. In summary, operating in the Arctic in the winter is challenging. Cold weather injuries are a complex problem, and there's not a one-size-fits-all solution. There are a number of factors at play, such as leadership, training, experience, equipment, individual risk factors, and behavior. These all play a role in cold weather injuries. By implementing active medical surveillance, we'll be able to better understand the extent to which the cold poses a risk to health and human performance during Arctic operations. Understanding how many of the injuries that are occurring, in addition to the mechanism of injury, will provide us with the information on how to try and prevent these injuries from occurring in the future. Thank you. Here are some papers that have been published on this project. The first one is on exercise Arctic RAM, and the next two are DERDC reports, one on the clothing and the second one on medical readiness. Thank you.
Thanks so much, Wendy. Great talk, and a very important issue, and it's getting increasingly important as there's increased interest in Arctic resources, and many countries such as Russia and China are expressing their interest in Arctic navigation, and recently there's been an interest from some of our allies, including the UK, about Arctic operations. So this is definitely an area that we should be leading in. So a couple questions that have come up is, you mentioned that the face seems particularly vulnerable. Are there any new fabrics or materials that are thin yet retain heat that we can make the face covering for our troops better?
Hi, Andrew. Thank you for the questions. Yes, right now, as I mentioned in the talk, there's this new piece of kit that a lot of troops are wearing that, covers the nose and is being used to help prevent their goggles from fogging, which is very important when you're on a long snowmobile patrol. But we're noticing it's mostly made out of like a neoprene, but we're noticing that there are now more cases of frostbite on the face. We're wondering if that might be contributing to that. On my NATO panel, which is on Arctic health and human performance, Norway has also noted that, they're noticing an uptake in facial frostbite injuries as well. So it's something that we need to look into. There are initiatives, moving forward where we are looking at different pieces of kit, some commercial, to see if we can improve this in any way. It's trying to remove the moisture from your face, which quickly can turn your face wear into frozen pieces of ice that you're wearing for long periods of time, and trying to balance that with not bringing 5 different pieces of face wear with you when you're out in the field. So yeah, we're looking into it. Thank you.
Yeah, another question from one of our audience says, great participation. If AMS is not possible, can PMS be improved? If so, how?
Good question. And yes, I do think that it can be improved. And it's something that we're looking into as well on our NATO group, is looking at improving awareness training for identifying that you are getting a cold weather injury. Sometimes, as was noted in the presentation, they're not always visible, especially if you're dressed, you're out in the field, for 7, 10 hours, and your body is covered, your hands and your feet in particular, you might not notice that you are getting frostbite, especially when you're talking about pain. And, what often happens is that people find that their toes or their hands are freezing, but then once they are, moving towards getting an actual cold weather injury, the pain goes away. So they might think that they're fine, but in actuality, they aren't, and they are they do have frostbite at that point. So we're looking at ways that we can increase awareness training on an individual, looking at individual risk factors and what can be done there. Can we help people identify if they are at higher risk, based on some individual risk factors, such as, even having a previous cold weather injury, and then what we can do there. And then from the leadership side as well, there's a buddy system that I know that they do use, but I think a lot of it is about, awareness and training moving forward.
Another question from one of the audience is, was there any data for members who wore locally purchased Inuit clothing pieces made with natural furs and hides?
Another great question, and another area that we're actually looking into as well, actually in a current study that's going on in collaboration with NRC. We did have some participants that were wearing pieces of equipment, in particular fur, that they had purchased. And, without going into too much information, it did appear that those people were, less likely to get a cold weather injury. That being said, there are a lot of other factors at play, and so it's hard to say for sure at this point if that's the case. But the people that did bring up fur and stuff, they definitely appreciated it.
Okay, one last question from one of our other audience members. They wonder if you could elaborate it a little bit more about buddy checks. What's your thinking around that?
Buddy check is when you're out and working with your colleagues, and you're able to identify if someone is at risk for a cold weather injury. It's easy on the face, for example. So when they're out there and it's windy and -50, people are wearing multiple pieces of equipment, and you might have balaclava on, neck gaiter, scarf, hat, hood, goggles, and looking for gaps in some of that equipment to see if there are some pieces of exposed skin. So doing those types of checks, especially before, say, a long snowmobile ride, 2 or 3 hours, that would help in preventing, some of those facial cold weather injuries. When it comes to, the other injuries, especially in, hypothermia, I guess it would be looking at other, kind of factors as well. Are people, slowing down? Do they, seem fatigued? In terms of the hands, people do remove their mitts quite often to do tasks that often require a fine level of dexterity and often require working with metal. So, trying to, maybe, work with them more closely to help identify if there's other ways that you can even complete that task without, removing your protective equipment. That would be helpful.
Okay, great. Thanks so much, Wendy. For our next talk, we're going to have Kevin Hofer presenting. Kevin's going to be speaking to us on cold stress of RCAF aircrew in a simulated survival scenario under Arctic winter conditions. Take it away, Kevin.
Good day, everyone, and welcome to our presentation about the cold stress of RCAF aircrew in a simulated survival scenario under ambient winter conditions. Next slide. I'm Kevin Hofer. On behalf of my co-presenters, we are from the Toronto Research Centre. We have no relationships with commercial interests. Next slide. This program has received no financial or in-kind support from any commercial organization, and I have not, nor my colleagues, received payments and funding from any organization whose products may be mentioned. Next slide. No measures were required to mitigate bias. Next slide. By the end of this presentation, I hope that you will understand that proper clothing is only one facet of survivability in the Arctic, that you recognize that training is critical to properly use clothing and kit and to build safe shelter, and that you gain an appreciation for the challenges that must be overcome to conduct field studies in harsh environments. Next slide. The Canadian Air Force is committed to a continued presence in the Arctic, and the Royal Canadian Air Force is obligated to keep aircrew safe during all flight-related operations, including downed aircraft scenarios. Our objective was to assess the ability of aircrew from patrol and transport communities to survive a downed aircraft scenario for up to 24 hours, using issued clothing and aircrew life support equipment. Next slide. The ability of aviators to survive a downed aircraft incident is critical to recovering personnel and maintaining operational capability. In this field trial, we observed aircrew activities, physiological responses, and subjective ratings in extreme cold temperatures at Crystal City, about 15 minutes west of CAF ATC, by a tracked vehicle. Next slide. 15 participants were organized into 2 groups. Group 1 was composed of 11 participants from the Aurora community, and Group 2 was composed of 4 participants, 3 from the Twin Otter and 1 from the Hercules communities. Each group performed a survival scenario and was asked to behave as if they were awaiting rescue. They worked on staying warm, preparing food and water, and building a safe shelter. The survival scenario began at noon and ran for up to 24 consecutive hours. Yes, it was cold. Next slide. We measured core temperature, heart rate, and chest skin temperature using EchoVital life monitors, finger and toe temperatures using MSR thermistors, and glove and boot microclimate temperatures using AlphaMock biscuits. Participants were asked for subjective ratings before, periodically throughout, and after cold exposure, and include the parameters listed here. We also asked participants to complete a cold weather injury survey and a clothing and equipment questionnaire, and that data was presented by Katie Mose, another TRC researcher. To avoid cold weather injury and for safety, participants' experimental session was ended if a termination criteria was reached. For example, extremity skin temperature of less than 5 degrees Celsius. Next slide. Activities included tasks categorized as pre-cold exposure, during cold exposure, and post-cold exposure. Prior to cold exposure and indoors at room temperature, each participant ingested a core temperature pill and then was instrumented. Dressed in extreme cold weather clothing according to the RCA Flight Operations Manual, participants were given a safety briefing in an uninsulated shed. At time 0 of the survival scenario, they were given access to additional clothing and LC that would normally be found on their plane. They were then led to a gully about 100 meters away and asked to set up their camp. They received no instruction or guidance about required activities or survival tactics. Following cold exposure, the participants were de-instrumented and completed the clothing questionnaires indoors. Next slide. On to the results. So core temperature data in blue and test temperature data in orange are shown here as minute-by-minute means across time of day. For each graph, the core temperature scale is on the left side and the chest temperature scale is on the right side. Focusing first on group 1. They constructed a snow cave, but it was deemed unsafe, and so the data was collected solely during their time outside setting up camp. Each dashed line on this graph indicates the number of participants remaining at that time point. Participants bowed out because the termination criteria was reached. Following the safety brief, and after dressing in the additional clothing and walking to the gully to set up their camp, the test temperatures, core and chest temperatures rose modestly. Participants became more active setting up camp and building the snow cave, and the mean core temperature continued to rise until about 1500 hours, at which time it began to steadily decline over the remaining period of the survival scenario. In contrast, their chest temperature dropped at roughly 20-30 hours, and by 1400 hours, their mean chest temperature decreased to roughly 36.5 degrees, and thereafter remained fairly constant to the end of the survival scenario. After 12 hours, and failing to construct the snow cave, the last of the Group 1 participants bowed out. Turning attention to Group 2, you can see that their survival scenario lasted roughly 22 hours, almost double that of Group 1. The longer duration was primarily due to the construction of a safe shelter. About a third of their data was collected outside setting up camp, and about 2/3 was collected inside their snow cave. The dashed line at 2000 hours indicates when they entered their snow cave, and the dashed line at 700 hours indicates when they awoke the next morning. Comparing the time outside to the time inside, you can see an inversion at roughly 2200 hours. The participants are comfortable and warm in their sleeping bags, sheltered in their snow cave, and their chest temperature warms while the core temperature drops in line with the circadian rhythm. Next slide. Next is heart rate, presented here as a minute-by-minute means across time of day, with Group 1 data on the left and Group 2 data on the right. Again, the dashed lines on the left graph indicate attrition, while the dashed lines on the right graph indicate the time entering the snow cave and awakening. Focusing on Group 1, with 11 participants, they spent about an hour in a relatively inactive state. planning and delegating roles and responsibilities. During this time, mean heart rate was 90 beats per minute. Then, at 13:30 hours, their mean heart rate increased to 120 beats per minute and is indicative of their increased physical effort required to set up camp and construct a snow cave. Thereafter, heart rate remained elevated with a maximum mean heart rate of 134 beats per minute. Now focusing on Group 2, with only 4 members, they were able to quickly initiate their plan to set up camp and construct their snow cave. Their mean heart rate was 128 beats per minute, with a maximum of 156 beats per minute. After entering their snow cave to take shelter for the night, their mean heart rate decreased to 52 beats per minute. Next slide. Next, fingers and toes. First, fingers. The pattern of mean finger temperature of Group 1 was similar to chest temperatures. During the first 60 to 90 minutes, mean finger temperature increased modestly and then decreased rapidly to 10 degrees and below. Not all 11 members were equally physically active, and some may have removed hand wear layers for additional dexterity to sort through their ELSI kit when setting up camp. Thereafter, their mean finger temperature increased and then fluctuated with the level of physical exertion, but predominantly there was a slow and steady decline. For Group 2, the rapid initial drop in finger temperature did not occur, which reflects how quickly they were able to begin setting up their camp. Similar to Group 1, their finger temperatures fluctuated depending on the level of exertion, the types of handwear worn, and the removal of layers for improved dexterity. A slow and steady decline, however, is evident. Once they took shelter, though, we see a significant increase in finger temperature to a cozy 35 degrees C for the remainder of the night. Next slide. For toe skin temperatures, there's a similar pattern of results to what was just shown for the fingers. The main difference being less fluctuation of toe temperature with the level of exertion, simply because there was less choice of footwear and the participants had less reason to remove their boots. Next slide. The next graph is different. Instead of temperature across time, we plotted cumulative percentage of total time in the survival scenario across skin temperature. Group 1 is shown in blue and Group 2 is shown in orange. Closed squares indicate mean finger temperature and open circles indicate mean toe temperature. The skin temperature of 15 degrees, the vertical dashed line, is the critical threshold corresponding to a strong perception of cold and is manifested as increased discomfort, sensations of pain, and decrements in manual dexterity. The Group 1 finger and toe temperatures were below the 15-degree threshold about 57% of the time, and that's evident by looking at the top horizontal dashed line. Whereas Group 2 finger and toe temperatures were below 15% threshold about 28 and 38% of the time, and that's evident by looking at the bottom 2 horizontal dashed lines. For a more equal comparison, we compiled the Group 2 data during their time outside only. The results are shown in the table. The finger and toe temperatures were below the 15-degree threshold about 55 and 73% of the time, so the toe temperatures of Group 2 were colder than Group 1 for a greater percentage of their time outside. However, remember that Group 1 did have an attrition rate, and the coldest participants bowed out. In contrast, while Group 2 was inside their snow cave, their finger and toe temperatures were below the 15-degree threshold only 13 and 16% of the time. Next slide, please. Next, subjective ratings. For both groups, the mean thermal comfort rating for their fingers and toes remained at or less than 7 out of 13 for the duration of the cold exposure, indicating cold stress and an uncomfortable state. The thermal comfort of fingers and toes decreased gradually over the duration of the cold exposure. The lowest mean rating of 4 was observed during the final time point of the last 2 participants in Group 1. In contrast, Group 2 reported consecutive ratings of 7 throughout the time in their snow cave when they felt warm and comfortable. Next slide. Not surprisingly, the mean exertion ratings of both groups mirrored their activity levels, rising as they built their snow shelters, set up their camps, and lowering in the evening when snow cave construction and camp setup was done. Exertion was lowest for Group 2 during their overnight rest. Next slide. Neither Group 1 nor Group 2 reported feeling pain beyond a mean rating of weak pain. Next slide. After cold exposure, Group 1's positive mood, for example, excitement and enthusiasm, decreased, while negative mood, for example, nervousness and irritability, remained relatively constant. Group 2 scores showed a similar pattern. Positive mood increased initially as they began their scenario, but began decreasing throughout the afternoon and evening, reaching a low point 2 hours after entering their snow cave. The next morning, the positive mood increased, but 2 hours later, they recorded their lowest mean score. Next slide. Group size, team dynamics, leadership, and training are factors that could impact survivability following a downed aircraft scenario. Group 1 were all aircrew from the Aurora community. They spent most of their flying time over open water, and only 1 of 11 completed a cold weather survival course. Contrast this to Group 2. 3 were Twin Otter aircrew who operate in Canada's north, and 2 of these 3 completed the Arctic survival training. The lone Hercules aviator who joined Group 2 also completed the Arctic survival training and spends time operating in the north. Group 2 demonstrated more confidence and familiarity with the cold protection strategies, effective use of personal protective equipment, and in general, they were warmer for a greater percentage of time. With no place warm to spend the night, the last of the Group 1 participants were designed to pace about in the cold to stay warm. In contrast, Group 2 constructed a suitable snow cave with proper ventilation and remained comfortable through the night. Among Group 1, a combination of inexperience in the harsh Arctic climate, a lack of relevant training about how to use healthy kit and clothing, and the inability to construct safe shelter led to a slow but steady attrition over a 12-hour period. In contrast, Group 2 constructed a safe and usable snow cave, and though their mood suffered, they endured 22 hours of severe cold. Next slide. In conclusion, I would like to reiterate the main takeaways of the study. Protecting aircrew during Arctic operations requires more than simply providing members with specialized clothing and kit. These resources will only be truly effective for Arctic survival when combined with proper training. Among other skills, training should cover shelter building, a recurring and noteworthy point in this presentation. Although studies of this nature are challenging, valuable insights are gained. 3 upcoming studies are planned. The first is an in-house study looking at heated clothing. The second involves instrumenting participants for the upcoming 2022 Arctic survival training course. And the third will investigate the cold stress of RCA rotor-ribbing aircrew. Finally, I have some reference for you to peruse. And if there's any questions, I'll be happy to entertain them. Thank you.
Thanks so much, Kevin. What a great presentation on such an important issue for our aircrew. There's a couple of questions coming in from the audience. And the first one being is, why were the participants separated by aircrew instead of being split into 2 equal groups? Maybe you could elaborate on that.
Sure, good question. And in fact, the initial plan of the study was to have some of the Hercules community send us some more of their aviators, but in fact, I guess it's a very busy community, so we were only able to get 1 Hercules pilot. So while we had 11 participants from the Aurora community, which was a great number to have, and they were manageable and we were collect the data, having only 1 Hercules pilot alone, it just made sense to really put that pilot in with the Twin Otter community. And I guess more importantly, in terms of answering the question, is that the different airframes actually come with different LC kit. So we also, of course, wanted the communities to use the kit that came with the plane. But again, I guess in hindsight, we perhaps could have had the lone Hercules pilot have a scenario where he was that participant was the sole survivor and had him out on his own. But again, just because of logistics and the time we had for the study, it just made sense to group the lone Hercules pilot with the 3 Twin Otter participants and keep those Aurora pilots or aviators separate.
Okay, great. There's another question coming up here. Why was Group 1's snow cave deemed unsafe, and and what were the temperatures inside Group 2's snow cave? Further to that,
that's sort of the what's in the bag scenario there. I mean, we sort of kept that quiet throughout the presentation, but essentially it came down to the fact that the group the group one snow cave was not designed properly because they didn't have proper ventilation and they didn't have a proper well. So that actually relates back to I guess the sort of first university chemistry. We've got a potential for carbon dioxide with lighting candles inside. So carbon dioxide is actually a bit lighter than air. So it would actually, if there was proper ventilation, the carbon monoxide would actually, I guess, disperse out through the top of the cave. That wasn't the case for group one. And as well, you could have, of course, carbon dioxide, and that actually is heavier than air. So ideally, you want a bit of a well at the entrance to the snow cave, so that carbon dioxide could sort of find its way. It's sort of denser than air, heavier than air, would find its way down to the bottom. So without group one having the proper ventilation above and without them having a well below, those two types of gas, that could be very harmful and detrimental to their outcomes. We could actually, in very severe cases, you could end up with some deaths. But of course, that wasn't the case with our study.
Okay, and one last question. Why did group 2 finish at 22 hours if the cold exposure period was meant to last up to 24 hours? Was there any safety concerns with that?
Yeah, that's a good question. It's sort of there's a bit of a background to that. So group 2, as you know, they did a great job. They were very familiar with the kit. They built a proper safe snow cave, and I think there was sort of some mention of this when you consider that their mood scores were quite low as that morning wore on. They had just spent the night in a confined snow cave, and I think it really boiled down to the fact that they were sort of getting bored, and they had some inkling that perhaps the study was going to end, sooner than later, and it was sort of a self decision that they would end the study at 22 hours. And I will say that they were given a little bit of a finger wag when they came up the next morning. They should have waited for the official end of the study or for the experiments to come down, but nevertheless, they did do a great job. They did last 22 hours, and it gave us some great data to show that having the training and building safe shelter is critical critical to surviving.
All right, thanks so much, Kevin. That was a great talk, and thanks for answering the questions. The next speaker up is Eric Robitaille, who's going to be talking to us about a study called Generating Resilience to Injuries Through Training, GRIT, a feasibility study. So we're really looking forward to this, as this is generating resilience is something we all want to bring to our CAF population and our veterans community and everyone. So we're really looking forward to this talk from Eric Robitaille. Take it away, Eric.
Hello, my name is Eric Robitaille, and I'm a federal service physiotherapist with National Defense and a clinical researcher funded by the Surgeon General's Health Research Program. I represent an esteemed group of National Defense healthcare professionals and exercise physiologists today, and thanking the CIMVHR Abstract Committee for allowing me to share the results of our feasibility study entitled Generating Resilience to Injuries Through Training, or GRIT. I have no commercial interest to disclose. This program has received financial support from the 4th Canadian Division Training Center in the form of funding for training equipment and in-kind support from the Directorate of Fitness and DRDC and CF Health Services in the form of testing equipment and human resources report. The 4th Canadian Division Training Center had no role in data collection, analysis, interpretation, or manuscript publication. And our objectives today is that following this session, you should better understand the evidence-based recommendations in MSKI prevention during physical training of military personnel and be able to apply these recommendations in a practical setting. So musculoskeletal injuries, or MSKI, are a primary threat to operational readiness and medical returns to unit, or RTUs, from the Developmental Period 1 Infantry Course, or DP1 course, at the 4th Canadian Division Training Center. Lower extremity overuse MSKI are the most common cause of RTUs on the DP1 at the 4th Canadian Division Training Center. Now, standardized progressive marching and physical training, or PT programs, of at least 9 weeks in duration have demonstrated a reduced overuse MSKIs of at least 33% without loss of fitness in recruits. It remains to be seen if this applied to DP1 candidates. Now, the DP1 training plan has no standardized progressive marching or PT, but candidates must achieve the load-bearing march, which is a 13-kilometer march while encumbered with full fighting order, which weighs approximately 24.5 kilos. Now, one of the challenges at the 4th Canadian Division Training Center is that candidates only arrive days or weeks before their DP1 and then deploy to the field at week 5, which makes further physical training not feasible. So the purpose of this was a prospective cohort feasibility study attempting to integrate standardized marching and PT into the DP1 course to determine, is it feasible to implement a standardized marching and PT program on the DP1 at the 4 CDTC, and determine any differences between DP1 candidates participating in standardized or usual marching and PT when considering metrics of operational fitness and MSKI. So the standardized marching and physical training program was performed 60 minutes per day, 6 days per week. Its primary objective was to progressively build tolerance for the load-bearing march while integrating known injury profiles and adapting existing best practices from studies investigating injury risk reduction while training military personnel. So the standardized marching program was held once per week, which began with a progressive load starting at 16 kilos and progressing towards 25 kilos over 4 weeks, followed by a progressive distance starting at 5 kilometers and progressing towards 13 kilometers in 9 weeks. Candidates were formed up by height, with the shortest candidates leading the march, and were encouraged to progressively challenge uneven terrain. The strength training program occurred 3 times per week and reflected the functional demands and known injury profile of DP1 candidates. The exercises you see illustrated here were performed for 3 sets of 8 to 12 repetitions until momentary muscular fatigue at a repetition speed of 2 seconds, 1 second, and 2 seconds per rep, and 2 minutes rest between sets. The running program was held twice per week, with the candidates divided into what's called an ability group. So based on their completion time of 2.5 or 2.4 kilometer run, they were stratified into 4 groups, alpha through delta. There was 1 distance run per week and 1 interval run per week, both limited to 30 minutes in duration. And each stratified group had a standardized progression. So you can see where I've highlighted the Charlie or C group, which at week takeaway 4 started at 20 minutes of running at a 5-minute and 30-second kilometer pace, which progressed towards 30 minutes by week takeaway 2, and then changed to a duration of 20 minutes, where the pace increased now to 5 minutes and 15 seconds kilometers per minute. So if I can draw your attention to the yellow boxes, the DP1 course is 13 weeks in duration. The first 5 weeks are in garrison, and the next 5 weeks are in the field. The field is not conducive to a regular PT program, so we asked the 4 CDTC for 4 weeks of pre-DP1 time while the candidates were in garrison to give us a total of 9 weeks for the standardized marching and PT program. If we look at the green boxes, we had 3 standardized courses throughout that fiscal year, and they follow the standardized marching and PT program just described, led by fitness staff prior to the DP1 course beginning, and then by DP1 staff during the first 5 weeks of their DP1. If we follow the red boxes, we can see that 3 usual training courses. That was led by the DP1 staff and at their discretion both before and after the DP1 course. If I draw your attention to the blue boxes, we had our outcome measures of force being measured prior to and after the standardized marching and PT program, And the final blue box at the bottom of the screen was that all MSKIs were reported to the Health Services Center through their sick parade. So our measure of operational fitness was the force test as assessed by PSP staff. A force test is a valid and reliable indicator of a CAF member's ability to complete the essential military tasks and include 4 parts: the sandbag lift, intermittent loaded shuttles, 20-meter rush, and the sandbag drag. MSKIs were assessed by Health Services Center staff and defined as suspected physical damage that would limit the ability for candidates to do physical training for equal to or more than 2 days. These were divided into acute MSKI, which occur from a single known event or accident, such as a fall, a slip, or trip, or overuse MSKI, which occur gradually over time from repetitive sustained activities such as running or marching. MELs are the activity limitation recommendations determined by Health Services Center staff, where duration in days serves as an indicator of their severity. And RTUs are the formal removal of a candidate from training as decided by military leadership. So the 3 courses in the standardized cohort included DP1 course number 54, 57, and 58, while the usual cohort included 55, 56, and 59. And our sample appears representative of the population of DP1 infantry candidates. They're young, predominantly male, and normal to slightly overweight according to the BMI. Of interest to us was 76% of the standardized cohort and 63% of the usual cohort acknowledged a history of injury prior to baseline. So for example, sustained during basic military qualification. And the most common injury history was an overuse condition at the knee, such as patellofemoral pain syndrome. This is the mean difference between baseline and follow-up for the composite force score expressed as a percentage, and according to either meeting the standard, the bronze, silver, or gold level. We can appreciate a gradual improvement in the standardized group from either a pass or a bronze score towards a silver or gold score, while in the usual group, it seemed to be more of a collapsing of results from the extremes towards silver. This is the total acute and overuse MSKI in both groups. While not statistically significant, we can appreciate notable differences in the proportion of overuse MSKI between groups, or 13% in the standardized group and 41% in the usual group. 4 CDTC stakeholders had determined a priori that a difference of equal to or greater than 25% in overuse MSKI between groups would deliver an operationally important difference by limiting their associated burdens. When the proportion of overuse MSKI in the standardized group is subtracted from and divided by the proportion in the usual group, there were 68% fewer overuse MSKI in the standardized group. This is the total and mean MEL days between groups. And there was a significant difference between groups where the standardized group reported 296 fewer MEL days. While this metric has clear administrative and training burdens to DP1 candidates and staff, it can also be used to calculate the economic burden of MSKI through time loss. This is the total RTUs due to an MSKI, which was further subdivided into acute and overuse. While not statistically significant, we can appreciate the notable difference between groups, where the standardized group reported 11 fewer RTUs. And this metric may be used to determine training center competence, but ultimately affects operational readiness of the infantry as a trade, and thereby the force strength of the Canadian Armed Forces. Local stakeholders in health services, the 4th Canadian Division Training Center, and Morale and Welfare Services agreed that study processes posed a manageable demand on resources without compromising training operations on site. Furthermore, they agreed that avoiding the associated burdens of overuse MSKI during the DP1 outweighed the resource demands of the study. Now, as a prospective cohort feasibility study, this study shares the limitations of other observational studies, including a lack of randomization, allocation concealment, and blinding of participants. However, our baseline measurements demonstrated no significant difference between cohorts in the outcomes of interest. And for CDTC medical and leadership, who determined MSKI and RTUs, were both blinded to group allocation. Our cohorts did have very few female participants, which limits our ability to explore any sex-specific influences. And as this study did not include formal measurements of fitness, we cannot claim that the differences between cohorts were due to changes in fitness as a result of standardized program. In conclusion, this study determined that it was feasible to determine standardized marching and PT on the DP1 course at the 4 CDTC without affecting operations. And standardized marching and PT led to fewer overuse MSKI, MEL days, and RTUs than usual training. And this led to an increased number of DP1 graduates and less associated burden on 4 CDTC. My colleagues and I are thrilled to report that our findings were recently published in the Journal of Science and Medicine in Sport. We are currently continuing the GRIT study at the 4 CDTC and trying to look at the sustainability of maintaining a standardized marching and PT program, as well as contributing to the force balance metrics. We are interested in determining the generalizability of our findings in other combat arms occupations and are actively recruiting peer sites. If you think that's of interest to you, I've left my email on the bottom of this slide, ericrobitaille@forces.gc.ca. And here are the references we've used for this presentation. Thank you for your time and your attention.
So thanks for that talk, Dr. Robitaille. I wonder if you could talk a little about the physical training for the control groups. Was at the discretion of the DP1 instructors? Can be summarized how their physical training differed from the evidence-based group?
So the question, Dr. Beckett, was...
Thank you for that question, Colonel Beckett. Overall, if we were to compare the two groups, there was a much higher frequency of the rucksack marching in the usual groups. That may lead to the reader considering that the DP1 instructors seem to favor rucksacking as a source of physical training. Again, overall, we also saw a notable decrease in the amount of running and certainly a higher decrease in frequency in the strength training. However, even if we look at the different courses that made up that usual cohort, we saw a lot of rucksacking in one of the courses and not as much rucksacking in another course. What that means is there's a lack of standardization in the DP1 physical training program, which was really the impetus for this study. So we think that moving the standardized program to more of an evidence-based platform can contribute to a larger decrease in the musculoskeletal injuries, in particular, overuse injuries of the lower extremity when it comes to the infantry in particular.
So the next question that came up in the comments is if CAF stakeholders were interested in implementing a similar program on their base wing at sea, what advice would you offer?
To further elaborate on the peg tube as well, when we are talking about...
Thank you, Colonel. The first piece of advice I would offer, and we think back to the slide where I had the handshake between the individual with a military arm, so to speak, and a civilian arm, and they're shaking hands. The first piece of advice I would say is engage your local stakeholders. The early planning that we did for this study, half of our time was spent just getting to know each other, the defense team members at the local site where you're considering such a program. So in our case, that was PSP representation, physiotherapy or health services representation, health services being capturing the injury data at the site of sick parade. We had training center staff, so the DP1 instructors, of course, their chain of command, and then representation from leadership. I think we can all agree that the implementation of any program on any training site will require leadership support. and we had very strong leadership support from day one. That doesn't mean we didn't have to build up the team, so to speak, of local stakeholders, and we certainly went through our storming phase of group formation. But I'm very pleased to report that we've been through several leadership changes on the site, and every commanding officer in that position has strongly supported this program. I'd like to point out that we did outline how we initiated and implemented this program at the 4th Canadian Division Training Centre formally by submitting it to the Canadian Army Journal. And I believe that's going to get published next month, or certainly the next revision. So I think that's 19.2. So sites that are interested in how we initiated or implemented that study are welcome to either contact me or look at that publication in the Canadian Army Journal.
Great. So thanks so much, Eric. So one last question. Given this physical training program was considered feasible by stakeholders involved with the CAF basic infantry course, do you think there is generalizability to other combat arms courses or populations?
Thanks for that question, Colonel. I strongly believe that when we look at the evidence for the Army in particular, and that's where a lot of this evidence is in trying to look at physical training as a primary prevention strategy, it is strongest in our Army populations. So Army populations being comprised of, combat arms being comprised of the infantry, the artillery, and the armored. So the theme of less rucksack marching and a gradual progression over time, the theme of less distance running and limiting that to 30 minutes, and the theme of a increase in strength training with external loads, as opposed to calisthenic or bodyweight exercises, would apply to other combat arms trades. If I think of the artillery and the armored as other trade examples, perhaps there are differences in between those. So armored personnel may have less need for the lifting required compared to the artillery personnel, who may need to lift heavier things more frequently. So certainly there will be variations in that standardized program, and that speaks to the necessity of having a live observation of their training programs or their demands for their training plan, and engaging local stakeholders that have intimate knowledge of those demands so we can make sure that the training program reflects their functional requirements.
Great. Thanks so much, Eric. I'd like to thank all of our speakers today for giving such excellent talks on very critical areas to CAF research and to veteran stakeholders as well. Congratulations on all the great work, and I look forward to seeing how all these projects evolve in the future, because, you know, as a Canadian Forces member myself, I know we all need it, and I have to pass my force test too every year. So with this, you know, one thing I have to keep working on as well. So yeah, all this research is tremendous, and a great credit to the Department of National Defense and CIMVHR's very gracious support for all this amazing work. And thanks so much to all the speakers today. And I'll hand it over now to Dr. Dave Pedler to give some closing remarks.
So that wraps up day 3 of CIMVHR Virtual Forums oral presentations. Before we all continue with our day, I would like to encourage all students to visit the Student and Postdoctoral Engagement Committee webpage under the About Us section of the CIMVHR website. Our SPEC committee is growing, and we're looking for engaged students with a passion for military, veteran, family, and public safety personnel research to join the committee. Please take a look and learn more about this opportunity. Finally, I would like to pass along a huge thank you to Ms. Tamara Kleinschmidt and Lieutenant Colonel Andrew Beckett for doing an exceptional job on leading today's sessions as moderators. The CIMVHR team and I appreciate your dedication to the success of the forum. To the researchers who presented today, thank you for the time and effort you put into developing your presentations. It was an outstanding day of presentations. I look forward to seeing everyone next Thursday, October 28th, for day 4 of oral presentations that will focus on the public safety personnel and veterans. To all of you and your families, please stay safe and be well. Thank you.